Hello and welcome to Neurocognitive Part 1 lecture. We're going to be covering a lot of neurological concerns, among them multiple sclerosis, Parkinson's disease, viral and bacterial meningitis, encephalitis, and we're going to take a brief look at headaches. You might have one by the end of the lecture. Let's start with multiple sclerosis. It's more common than you would think. This disease has periods of exacerbation and remission, because it's scarring of the meningeal tissue. Do you know what meningeal tissue is? Yep, it's in the brain and it's on the spinal column. Now this disease doesn't respect any age. It's more progressive over the age of 50, but that might be because of many other comorbidities. And unfortunately, this one affects more women than men. Etiology and pathophysiology, well, guess what? The cause of multiple sclerosis is unknown, but it's unlikely to be related to just a single cause. The disease develops in somebody who is susceptible as a result of environmental exposure, like an infection. Maybe some of the precipitating factors would include infection, maybe smoking, physical injury. How about that awful emotional stress? Excessive fatigue, pregnancy, that's a stress on your body, folks, and a generalized poor state of health. The role of these factors, such as exposure, is kind of controversial, but there are more than a dozen viruses and bacteria that they've looked at, and none is really clearly the cause of multiple sclerosis. Genes are believed to be involved in the inherited susceptibility of this disease, and if you have a first-degree relative with multiple sclerosis, you might have an increased risk. So they're doing all kinds of genetic experimenting and finding out families that have more than one affected member and if there's a link there. Okay, etiology and pathophysiology. Well, it causes damage to the myelin sheaths of the neurons in the brain and the spinal cord, but the nerve fiber itself is not affected. It can be slowed, but at this point, myelin can regenerate, and the symptoms will fly away. The patient might complain of some noticeable impairment of their functions, and with this ongoing repeated inflammatory process, the myelin can sometimes become unable to regenerate, and then the damage that was there is now permanent. So at what point does the patient experience a remission? When they're able to regenerate the myelin sheath. So what does this mean to you? Yep, periods of exacerbation and remission. What do they look like? So here's your picture. There's a 32-year-old woman. She went in for her annual physical. Everything was looking okay. This young woman, well, I know her. She happens to be a graphic artist and an author. She went in to tell the doctor that she was having some visual problems, and she'd had her eyes checked, and she got new glasses, but nothing was getting any better. Being a graphic artist, color is an important thing, and she was really having trouble looking at coloring, red, green especially. The doctor was looking at her, and his eyebrows went up. He said, I think we need to do some further testing. So now let's go forward a few years. This young author, she was a maid of honor at my daughter-in-law's wedding. Lovely person. They'd known each other for years and years and years. Life had gone on. She had a couple of kids. But now she's extremely fatigued, and it isn't just in taking care of the kids. She even had to start using a wheelchair on occasion. When she was pregnant, things got a little bit better, and then they got worse again. Yep, you guessed it. She's got multiple sclerosis. Now, let's go forward some more. What would she be like? Well, sometimes she can walk. Sometimes she can't. She's wheelchair bound. Sometimes it's really hard for her to remain intact. She gets a bit confused sometimes. Sometimes she has urinary problems. Did you notice the word sometimes? Well, this is an example of periods of exacerbation and remission. Can you see her? Do you think she's going to get better? Well, is there a cure for multiple sclerosis? Well, Here you go, your clinical manifestations. First set of symptoms. Take a look at what they are. Vision rears its ugly head here. More common manifestations of it, motor, the walking, she had to be in a wheelchair. Sensory, it was hard for her to know if the stove was hot. We have cerebellar problems and emotionally labile. Some more manifestations. Weakness, spasticity, scanning of speech. You know what that is? Her sensory, numbness and tingling, pain, vertigo, neuropathic pain. You thought just diabetics had that. The muscles are chronically affected. Walking, standing is bad. Partial or complete paralysis, okay? Hearing loss. We can't cure MS, but we can treat the disease. So take a look at the medications that we use to treat multiple sclerosis. This table provides a whole lot of valuable information about the patterns of it, and there are different types. Okay, let's kind of go into headache. It's probably the most common type of pain experienced by humans. We all get headaches. Okay, so why do you have a slide on headaches? Well, it's something to consider. Maybe that headache is a sign or symptom of another problem. So instead of just giving them a Tylenol, ask them questions to determine if there are any other precipitating factors. Now, you learned when we were looking at hypertension that when a client states they have the mother of all headaches, that this may be a symptom of cerebral aneurysm or a stroke caused by hypertension. So take a look at the different types of headaches here: migraine, tension, primary, and secondary. We're now going to go on into Parkinson's disease, and this is a chronic, progressive, neurodegenerative disorder. Take a look at the words that we're using to describe this: bradykinesia, rigidity, tremor at rest, and gait disturbance. And it is very, very common anymore. Affects up to 1 million Americans. I wonder why that is occurring. It increases with age, and it's more common in men by a ratio of 3 to 2. I want you to meet somebody. His name is David. Now, David has Parkinson's disease. And besides the physical presentation, we need to consider Parkinsonian dementia as we're looking at this client. Parkinson's disease slows everything down. Their thought processes, their movements, coordination, memory. It does impact more men than women, and it's a chronic, miserable disease with lots of complications. Now, David was starting to shuffle his feet when he was walking. And you might think he was just lazy and didn't want to pick his feet up. When he was watching TV, his hands were going all the time with tremors. It made it really hard for him to use a channel changer. Do you think that safety is a concern here? Shuffling feet, hands moving, his muscles are rigid, and he does a lot of what they call pill rolling with his fingers. It's very characteristic. His speech was slow. Okay, we're going to go to the doctor and we're going to find the cure, right? No, you can't, because there isn't one. We treat some of the symptoms, but this disease is going to continue to progress. Unfortunately, there is no cure. They don't really know what causes it. It can be a whole bunch of different things: environmental factors, maybe the genetic makeup. We look at family history. What about well wall, pesticides, herbicides, industrial chemicals, all that kind of stuff? You know where David got Parkinson's disease? He was exposed to Agent Orange, a chemical. That's what gave him Parkinson's disease. But what is it? It's a lack of dopamine. Those are the producing neurons in the brain. And we have to have it or we don't function normally. And that's exactly what has happened to David. So as you look at this slide, there's a mnemonic there for you that gives you a picture. It's called TRAP. Tremors, I told you about those. Rigidity, he walks real stiff and shuffles. What is akinesia? Postural instability, safety, safety, safety. Big time. They trip, they fall, they're not sure where they're stepping. Their head is looking down, they don't see where they're going. In the beginning, mild tremor, slight limp, and they have a characteristic arm swing. Later on, they really shuffle, and again, a very specific walk. Not to be cruel or anything, but you've seen orangutans walk. That's kind of what the posture is. 90% of these clients experience hypokinetic dysarthria. They speak differently. Very strong abnormalities, and then the frustration occurs with that. Pill rolling, hand tremor, diaphragm, tongue, lips, jaws, they all get involved because of the muscle. Rigidity, take a look at that, and then the cogwheel rigidity, they're jerky with their movements. So this is a review of what your Parkinson's client looks like, and then to make it better, here's a picture. Meet David. Non-motor symptoms, depression and anxiety. You met him. Do you think he's depressed? Do you think he realizes all that he's losing? Think about how tired he is. It takes everything he's got to keep going. His hands are going all the time when he's at rest. It takes more energy to swallow, to do very simple things. Where does the pain come from? Well, those muscles get pretty rigid and they atrophy. So yeah, he has pain. Yep, urinary retention. Erectile dysfunction, women don't have to worry about that. And one of the difficult ones is the memory changes that occur. Think how frustrating that is. That feeds into the depression and the anxiety and even anger. Sleep problems are common. They're very, very tired. They can't remember anything. Now they can't even sleep. Complications. As you're looking at this list of complications, think about the safety concerns for each one of these things. Falling, wandering, aspiration pneumonia, other pneumonias, infections, skin breakdown, hypotension. So how are you going to take care of this client for 12 hours? There isn't a specific test for Parkinson's disease. You look at them, you assess them, and you take a history. Clinical diagnosis does require the presence of TREP, and that's the mnemonic that I gave you earlier. Okay? Confirmation is a positive response to the anti-Parkinson's drugs, levodopa, carbidopa, or a dopamine antagonist. So there you go. Levodopa with carbidopa, Sinemet, that's the primary treatment. And we give it all the time. But the problem is with Sinemet is if a little is good, we're just going to keep marching up until we give them more and more and more and more. But do you think that might cause a problem? What if they had too much going on? They were rigid. Now they're loosey-goosey and floppy if they have too much. So think about that. How will we know? Well, assessing your client. And we can very easily flow into an overdosage of carbidopa levodopa. Think of the problems that would cause if their muscles are very loosey-goosey. Do they breathe well? Can they swallow? What's their balance like? Now we're going into delirium. The three most common cognitive problems in adults, older adults: dementia, delirium, and depression. And guess what? They all kind of feed into each other. Depression is often mistaken for dementia in older adults. And sometimes dementia is confused with depression. So take a look at what depression looks like. Maybe they're sad. Oh, they're sad because they're losing all their friends and their family. Okay, maybe they can't think and concentrate. Oh, they're just old. Fatigue, apathy, all those good kind of things. But when depression is real severe, concentration and attention cause memory and functional impairment, and this is when it gets dangerous. When they occur together, they deteriorate very, very, very rapidly. The person who is alert, oriented, and living life to the max now can't even pick out clothes to wear for the next day. So depression, it's treatable. And in combination with dementia, it's treatable. but we have to make an accurate and early assessment. So you have a table in your textbook, Table 59.1. I would suggest that you look at that. So we're looking at delirium. How does it happen? Stress, surgery, sleep deprivation, pain, and depression. Harken back to when you looked at perioperative. These people are scared. It's unknown territory. They're afraid of dying. They don't understand what is happening to them. Do you think that we can push them into delirium? Because we're calming them down. We're giving them drugs, aren't we? So dementia is a leading risk factor for delirium. Delirium is a risk factor for dementia. Stress, surgery, sleep deprivation is one of the big things that's been linked to the onset of this delirium. Pain, depression, they can also contribute in the post-operative older patients. Remember that these folks may have a problem with metabolizing the drugs that we give them in surgery. Do you think that might have an impact as well? So here's your precipitating factors for delirium. Older than 65 and males. We put them in the ICU. We tie them down because they don't understand that they can't pull at things. They may have pain. And if we're going real light on the medication, maybe we're not treating them well. Emotional stress, they're away from home and everything, and they're scared to death of what's happening to them, and they don't sleep. They're awakened every 2 hours for blood draws. The machines are beeping. The ventilator is going off. They don't know if it's day or if it's night. They don't know who you are or who all these people are coming in and poking at them. Maybe we have them dehydrated. Maybe we're not giving them feedings. All things to consider as you care for this patient. Drugs, there you go. Sedatives, opioids, anticholinergic may have a huge impact on the elderly patient population. Aminoglycosides, you know what those are. And if we're giving them kind of a whole plethora of drugs, are they interacting well in this patient? Now, everybody says they don't drink. Or if they do say they drink 1 beer or 1 glass of wine a night. So take that times 10, folks. Now we're pulling it away from them. So as a nurse in a hospital caring for them, this delirium occurs frequently. And that's because they're hospitalized, they're out of their norm, and because of the care that we're delivering. So it's real important for the nurse to recognize delirium and to search for those factors that are actually causing it. Don't just ignore it. Here's your mnemonic, things that can cause delirium. I would take a real strong look at it, and here, a picture's worth 1,000 words. Different types of dementia. Vascular, Lewy body dementia, which is a horse of a totally different color, and then you've got your Parkinson's disease as well. Now we're going to kind of go into Alzheimer's. That's a form of dementia. It's probably the most common nowadays. 60 to 80% of all cases of dementia. So you can see it's got a goofy name, right? Well, it was a German doctor in 1906. He figured it out. He said the changes in the brain tissue of this 51-year-old woman, she died. She had mental illness. They couldn't figure out why mental illness would have killed her. So they dissected her brain and looked at the tissue under a microscope. And actually the brain was much, much smaller than a normal brain should be. Well, Alzheimer's is a fatal disease. Death typically occurs 8 to 10 years after the diagnosis. Some people live longer, but think about the quality of life for those 8 to 10 years. They aren't the people that they once were. And how do we diagnose it? Well, the German doctor did it. When they die, we'll get a tissue biopsy. We'll look at the shrinkage of the brain tissue within the cranium. Okay, on the left, normal brain. Guess what that is on the right side? Yep, that's Alzheimer's. Look how it has shrunk down. What do they look like? Cognitive impairments, dysphagia, apraxia, visual agnosia, dysgraphia, inability to recognize family and friends, and wandering. Okay, dysphagia, maybe they don't understand what you're saying. Apraxia, they can't do purposeful things. They will reach for something and be way off base. They can't button a shirt. They can't zip a zipper. So maybe these people should have Velcro on their clothes. What do you think? Or use a zipper. Dysgraphia, they can't write. They'll write down letters, but nothing makes any kind of sense. Now, short-term memories, first thing to go, but long-term memories are also bad. They can't recognize family members and friends. They may become aggressive, and they get lost. A lot of the things that you see on the freeway with silver alert might be somebody who has Alzheimer's disease. They have an intention to go somewhere, but they don't know where they're going. But for some reason, they can still remember how to start that car and go, but they may not go the right way. There's nothing sadder in Alzheimer's disease than when family members come around this person and they kind of look at them and cock their head and they don't have a clue as to who they are. Very sad disease. I did tell you how we diagnosed it. It's diagnosed by exclusion. They don't have Parkinson's, but they do have Alzheimer's. It's pretty much our last reach at a diagnosis because there's so many other cognitive disorders that are around. We do have to do the autopsy. They are looking at a whole lot of genetic testing and biomarkers, amyloid accumulation in the brain. You're going to see that more with Lewy body, or if the nerve cells are actually damaged. Interprofessional care, you know there's no cure. There's no treatment. We can't stop the deterioration of the brain cells. So we're going to take care of them to the best of our ability. We're going to control undesirable behavior manifestations. Don't let them hurt themselves. Safety is massively, massively important. Perhaps they should wear a bracelet that says who they are and that they have Alzheimer's in case they wander. Nothing stops or slows down the progression of the disease. It is indeed fatal, but something I really, really, really want you to think about is this is a disease that impacts the whole family. So providing support for that family caregiver is vastly important. They do give drugs for this. They help. Some do. Some, maybe that's hope, I don't know. But if they do help, it's not going to help for very long. There's no effect on the overall disease progression. Okay. Dementia diagnosis isn't impacting the client, like I said. Be aware of that caregiver role strain. It's huge. And the nursing role that you can provide to that caregiver. Give them information. Let them know what's out there to help support them, to minimize the impact on the family and on those caregivers. Okay, let's go into some inflammatory brain disorders right now. Most common inflammatory conditions of the brain and spinal cord are brain abscesses, meningitis, and encephalitis. Mortality rate is there, but they may have those long-term neurological defects. So this inflammation can be caused by bacteria, viruses, funguses, chemicals. Do you know even IV contrast media can do that? Blood in the subarachnoid space. How did that happen? Maybe a trauma? Central nervous system infections can occur during the bloodstream. How does that happen? Ever go to the dentist? Ever have your teeth cleaned? Ever have a tooth pulled out? Well, the mortality rate for inflammatory conditions of the brain is 10 to 30% in the general population, but in older patients, it gets higher. So think about long-term neurological effects. Brain abscess, yuck. Similar to meningitis and encephalitis. How in the world could you get it? Remember I mentioned abscess tooth? How about pulling a tooth out? You went to the dentist, and guess what you got? A brain abscess. Maybe you had a lumbar puncture done, and it was leaking, and it got infected, and then you got another abscess. So now what does this brain tissue look like when you have a brain abscess? Well, it's irritated, could be swollen. Does that mean that you're going to have an increased intracranial pressure? Yep. How are you going to care for them? But how do we know that it is an abscess in the brain? Well, we're going to probably get some spinal fluid. Maybe we're going to get some blood cultures. Maybe we're going to do a CAT scan. We have diagnostics to tell us that there is something in the brain that should not be there. How are we going to take care of them? Well, is the abscess bacterial or is it viral? Are we going to treat it with antibiotics? You better believe we are. And we're going to treat it with antibiotics after we get some cultures. Because we don't know if it's viral or bacterial. We're going to assume, right? But we have to get the cultures drawn before we even start the antibiotic therapy. Here's some leading causes of bacterial meningitis. Look at them. Streptococcus pneumonia, Neisseria meningitidis, and you used to be able to get it through an existing Haemophilus influenza vaccine, but they got rid of that one. Organisms can enter through the upper respiratory tract or through the bloodstream. Skull wounds, fractured sinuses, somebody got punched in the nose. Guess what? Now they have bacterial meningitis. It's pretty common. And remember that your meninges covers the brain and the spinal column, so it's all inflamed. So what happens with it? Inflammatory response, we got to get that cerebrospinal fluid increasing. Secretions spread all through the brains. We get increased intracranial pressure because it swells. A young adult comes into the emergency room, and they're complaining of a headache. They're agitated. They're kind of crabby and irritable. So what do you think is going on? They say, can you kind of turn those lights down? They hurt me. You're assessing them, and they will not bend their neck because it's stiff and it hurts. That's called nuchal rigidity. Oh, they got a fever. Doctor, come to the rescue. Okay. Might be meningitis, so let's get some cultures. Let's start an IV, and let's get some antibiotics going. Okay, very specific manifestations of bacterial meningitis, right? What are you worried about? How are you going to take care of them for your 12 hours? Well, you're going to assess them neurologically. Yep. Check the vital signs. Yep. After you send the cultures, get those antibiotics going. Do you think you might want to initiate seizure precautions? Well, what are they? They might be throwing up all over the place. Severe nausea. They have a bad headache. So if we don't treat it, what happens? Okay, that brain's going to continue to swell. All right. They can have seizures. They can have palsy. Their heart rate can go down. They could go in a coma. They could even die. So headaches can occur for months after the diagnosis of meningitis until the irritation and inflammation have completely resolved. And it's important to implement pain management for chronic headaches. Bacterial, here's the studies that we do. When a patient has manifestations suggestive of this bacterial meningitis, a blood culture and CT should be done. How do we verify the diagnosis? We're going to do a lumbar puncture. Turn them on their side, washy the area, numbing medicine into the spinal column, stick in a needle, and have the fluid come out and send it to the lab. Then we remove the needle, put a bandage on, and lay flat on their back in bed for a period of time. We want them to increase their fluids now. We took fluid out. Do you know how long it takes for cerebrospinal fluid to be replaced after a spinal tap? 72 hours. So we have them drink fluids. Probably, you know what, a good one to give them is Mountain Dew soda. Or they can drink coffee because we want to constrict that spinal column so it looks like there's more fluid. We check them constantly to see if the sheets are wet or something. They're laying flat on their back, we're giving them fluids, and we're saying on your bed rest. They gotta pee, right? Think about that, so make sure that you have a bedpan or a urinal close to them. Then they go home, or they go back to their hospital room and they get up and they do their thing after being on bed rest, 4 to 6 hours. Well, if that cerebral tap doesn't seal off within 72 hours, they'll start complaining of a bad headache. We won't really do anything about that for 72 hours because you know that it takes 72 hours for that cerebral spinal fluid to regenerate, to get enough fluid. So if that headache is out of control after 72 hours, they bring them back in, do another lumbar puncture, but we do something called a blood patch. We actually draw blood from their arm, stick it in the spinal column, and it creates a patch. And then it does take a while for that headache to go away. Specimens of the CSF that we sent off, we can also get a sputum specimen, We can get nasopharyngeal secretions. Those are just different ways we can get it, but your lumbar puncture is probably the best one. And then they're going to do a gram stain to detect if it's bacterial. They'll be on broad spectrum. Once we decide what the causative agent is, we'll become more specific with what we give them. Okay, bacterial meningitis can be a medical emergency. Rapid diagnosis is crucial. They're critical when we start. They don't come in just because it's a light headache. It's bad. We do start antibiotic therapy before the diagnosis is confirmed, but cultures are done first. Give them fluids, okay? Maintain therapeutic blood levels of the antibiotics, so you might be getting peak and troughs. And we're going to put them in respiratory isolation until the cultures come back negative. When it's suspected, like I said, see, these are some of the antibiotic therapies that we might think about would be ampicillin, penicillin, vancomycin, ceftazine, cefotaxime, rocephin, cefazox, Septaz. Those are some of them. Dexamethasone may be prescribed just to reduce the inflammatory process. Then the healthcare provider is going to give you some probably pretty potent medications to take care of the headache, the fever, and the nuchal rigidity. Viral. Okay, most common causes of viral meningitis are enterovirus, HIV. They're spread through direct contact with respiratory secretions. They usually present with a headache, fever, photophobia, the same thing. So is it viral or is it bacterial? Well, the brain doesn't get terribly involved at this point. So let's compare how it is to bacterial. Different way of getting it, isn't there? Presentation is kind of the same. How do we know it's viral? You guessed it. We're going to get the culture. We're going to wait for that culture to grow. It's going to take 72 hours. But we're going to treat this as bacterial meningitis until proven otherwise. It's a virus, usually self-limiting, and we give supportive care. So what does that mean? Fluids, rest, adequate nutrition, treat the pain of the headache, decrease the sensory overload. Do you think viral meningitis can result in seizures? Yep, it could. Diagnostic testing is done the same way. We get a spinal tap. You can do a rapid diagnosis with the expert EV test. Okay, we still have to get that cerebral spinal fluid, and we can get usually a result available within hours. We're going to treat with antibiotics after we get the specimen, and we're going to treat the symptoms. Like I said, full recovery is usually expected. Now, the CSF fluid can be clear or cloudy, and the typical finding is that we have lymphocytosis in it. We don't really see any organisms in it. That would be bacterial. Okay, another one of these is encephalitis, and that's an acute inflammation of the brain. It's serious. It can be fatal and caused by a whole number of viruses. Ticks or mosquitoes is one of the things that they watch for closely. Do we have tick or mosquito-infested areas? And it's usually specific to certain geographical areas, and ticks and mosquitoes don't live well in 50 below zero, right? CMV encephalitis is common for the AIDS patient. We could have non-epidemic encephalitis as a result of measles, chickenpox, or mumps. Diagnostic studies, CT, MRI, PET, blood test for West Nile virus. Remember when that was very rampant here in the valley? Comes from horses first, they think. You have a table in your textbook for 56-16. Best diagnostic test for West Nile virus is a blood test, and that tells you about viral RNA. Okay. Nursing management. Well, it's a virus, so we're going to give antivirals. Zovirax. We want to reduce the mortality rate. They may have ongoing neurological complications. Yeah, start treatment before onset of coma. Good idea. Again, the brain is irritated, so we are going to have to watch for seizure, put them on seizure precautions, and they may be getting some anti-seizure medications. For maximum benefit, antiviral agents should be started before the onset of coma. That is such a stupid thing to say. treat the disorders with anti-seizure drugs, and we will prophylactically also give them anti-seizure drugs. Well, I've now kind of gone over our part 1 of neurocognitive with some disease processes. There will be more to come. I hope this lecture is helpful for you, and you can review it as many times as you want in the time that it's posted, which will be for 1 week. Bye now.